Good morning. Uh, okay. Uh, I will basically talk about the overview of the assessment and management of substance use in women. The outline of presentation is why the emphasis. The Professor Pratima Murthy has already talked about it, and I will cover in what is the summary of that, and what are the important clinical characteristic, which is different in females compared to the male substance users, and I will be covering in slightly detail about the assessment, the in four subheadings, the treatment principles in female, if it is some different from the males, the management overview about the pharmacological, non-pharmacological, what is the evidence base for the same, and in briefly about pregnancy and lactation, and finally I will conclude my presentation. So this, like in the last 2 to 3 decades, we have seen the increasing number of studies on substance use in the international, like Western countries. In the last decade, we have seen in Indian setup, like the national level data are also catching the female substance users, and their number is slightly increasing. The telescopic effect, which has already been covered earlier, and the reproductive consequences, which has also been covered. Whatever the clinical data we have in the Indian context, what we can get is that there is emerging patterns in the form of gradually narrowing of the sex ratios. Earlier, if you can see in the 1980s, it will be around like female numbers was not there, and in 90s and in 2000s also, now it is in one single digit compared to the male, but it is actually the ratio is decreasing. The number of females are increasing, and other thing is that increase in the use of illegal substances in females, and early age of onset compared to the earlier decades, and increase in high risk behaviors, particularly IV users and others, and increase report of violence among those who use substances. The aspect that mirrors the male substance use are difficult childhood in both men and women, poverty, low education, environmental adversities. The aspects that are unique to the females are the telescoping, high stigmatization, the complex spiral of adversity that the earlier speaker talked about, and high comorbidity. This aspect we will be assessing and why it is important in the next assessment slides. Now coming to the assessment, see, the assessment has broadly 4 components: the screening, diagnosing, planning treatment, and referral. And in all these 4 components, the rapport has to be established, and we have to motivate the substance user, that applies both to male and females, to do something about his substance use. The first one is the screening, where there will be a clinical reporting and structure scales to assess the use of substance in females. So here what has been seen in the literature is that the self-report gives a better picture compared to the health personnel applied results. So always better that whenever the females come to give a self-report, and they report by themselves. So there are few scales which are commonly used, the CAGE which is used, but what normally it has 4 items. If score of 2 or more requires further assessment, but in female Hispanics, what has been seen that even if the score is 1, then also is significant, and there is a need to assess properly in these cases, even if it is 1. Other scale is the audit one. It is similar in both male, and the scores also similar. So 8 to 15 simple advice, 16 to 19 brief counseling and follow-up, and if it's more than 20, warrant diagnostic evaluation for alcohol use disorders. This is for females. Now the scales I will be talking about, the screening that is also used in pregnancy. This is a tweak. This is for alcohol. The tweak is also available for others, like other substances also. It has 5 items. Cutoff score of 2 indicates the likelihood of risk of drinking problems, and other was TAs, which is for alcohol use. So it has 4 items. The cutoff of 2 or more then indicates the risk of having drinking problems. There is assist and other scales also being used. This is the scale particularly in the 5 P's we call it as the prenatal substance abuse screen for alcohol and drugs. The 5 P's, basically the first P is, if did any of your parents use substance or drugs or alcohol. Next is the peer, the second P is peer, the third is partner, fourth is past, whether you have used, and fifth is during pregnancy you have used. It is for both alcohol and other drugs also. The P5 as one component of smoking also is considered. If any one of them are positive, then there is a need for thoroughly assessment for substance use disorder in females, particularly in pregnancy. Okay, these are the few important screening instruments used in females for assessment of substance use in normally and also in pregnant females. Now coming to the detail about the assessment, what are the things we have to be assessing while assessing the substance use in female. The substance use, the substances, if you want, like what are the initiating factors, the reason of initiation that has been talked earlier also. In majority of the females it will be either the stressor or the husband was using and he was creating issues, and wife was regularly telling him that stop alcohol. When she drinks, she won't be talking about the husband giving alcohol for her to keep her calm. And majority of the initiating factors are, in majority of the cases, are there by the family members, particularly the husband, the father, and sometimes the initiating by the doctors who are treating them for pain. There the opioid use disorders and all those things also come. So initiation also slightly different from the male population. And reasons, the duration I already talked about, the earlier speaker also highlighted, the duration is telescoping phenomenon is common. In the Western countries, what is seen in then the telescoping phenomenon is not much in the community setting, but in the clinical setting it is still a important factors. So the starting of the substance use or dependence or starting or coming to the treatment network is shorter in female compared to the men. And the duration of abstinence, if at all in their lifetime, and what are the factors which made them to be abstinent on substances, and what are the protective factors, and what are the strategies they used to remain abstinent from the substances. The consequences like the earlier speaker also talked about, like the physical and the psychological consequences are high, the stigma and the complexities of like female, the child, the who is has supposed to be seen the child and what effect it has on the child rearing, and the long-term effect on the child if the mother was using the substances during the pregnancy and other things. So legal consequence also one of the important factors in females, the divorce, the violence, substance use and violence, the divorce, miscarriages and all those things. The treatment that I will be talking briefly what are in the overview in the next few slides. The signs of possible misuse, particularly those who are prescription use, misuse and all those things we have to be assessing in those who have opioid and others, benzodiazepine, opioids, if you are suspecting having a problem with benzodiazepine or opioids. And in particularly if they are pregnant, the females who are pregnant, whether they were using substances before or during the pregnancy, and the pregnancy history in the form of whether any negative consequences happened in the previous pregnancies, and if they are using during the lactation, the effect of substance on the child, because most of them are fat soluble, so it will go to the child and it will have some effect, the short term effect and long term effect. Other pregnancy complications like abortions, miscarriages, which I've already talked about, and use of birth controls in females that also have an effect on the duration of the effect. Also they will have effect on the pleasurable effect of the substances, and also they have an effect on sometimes on the mood, and that also affect the effect of the substance on the individual. The high risk behaviors, as the earlier speaker also talked about, in the recent years the report of high risk behaviors among substance users in females has been reported, and it is coming around equivalent to male, and in some countries it's slightly higher or equivalent to male also. We have seen that there is high physical and psychiatric comorbidity. The range from around 40 to up to 80% comorbidity. So we have to, whenever the patients or the females come with substance use, you have to check for physical comorbidity or psychological comorbidity. Most common is the depression, followed by anxiety and other like psychotic. There's a breakdown of psychotic episodes also sometimes because of the substance use. The family history, which has already been, the acceptance in the family, they will be, the child care needs have been, because if the parents of the are using, the children are being neglected and their needs are not being taken care of and they have their own problems. So these and all things will add up to the negative spiral, and this will have the consequences on substance use as a coping and also aggravating the consequences of substance use. The treatment history, the response to previous medications, the compliance, the whatever has been seen in majority of the studies is the compliance to medication, particularly in Indian setup, the majority of the patients will be lost to follow up. Wherever, like I have worked in two centers at this time, like majority of the females, they will be lost to follow up. The lost to follow up is higher in them compared to the male, and the side effect profile also has to be monitored. There is nothing particular, but we have to be monitoring regularly. I have just included this barriers to care in the assessment part only. There are three barriers to care for particularly female substance use. The systemic barrier is the lack of knowledge about the effect of substances or the treatment available for female substance use. The structural, which is most important, because when anyone female substance user come to the setup, whether if they are seeing all male patients, and they won't be coming up because they have to wait in the queue and they have to take the turns, and if they are they have a child who the child needs us to be, because they cannot be keeping them in the house for a pretty long period of time because the husband will be working and she has to take care of the young child also. So the structural needs, the setup wherever the female substance user will be assessed or admitted, we have to take care this aspect also, because these are the one of the barriers. The most common is the systemic, the lack of knowledge, the structural, because when there are large number, there is no particular things in the setup to take care of the particular needs of the females, and the social, cultural, personal factors. These are like stigma of substance is one of them. The culture, there are some females who are using substance will be castrated from the society and they will have negative consequences, and sometimes their children will be separated from them because everyone thinks that because of the substance the children will be also be using, and that will have a negative impact on the children, the mother substance use. So this aspect also has been the barriers. Knowing this important aspect is basically important because while managing we have to address these needs. If you are not addressing these needs, the chances of not coming to the treatment because of all these things, and also the psychological effect of if you are not educating the people around, the family members, how to handle them when there is a crisis, how to handle the stresses in the family. If you are not being handled properly, the chances of relapse and other problems are also more. Another important thing while we are assessing in female substance use are strengths and coping strategies. We already know that there is several like tragic events and the consequences, social, cultural, personal consequences. So the challenge has to be handled, and the coping mechanism has to be taught to the female users, how to handle them, and also the family members, how to handle the females with substance use also needs to be done. Mental status examination is similar in both males and females. The clinical diagnosis, either the childhood onset psychological conditions or the physical condition or the adult onset, and information should be gathered from multiple sources, and the diagnosis as per either ICD-11 or DSM-5 classificatory systems. The physical examination is more or less similar, and with some particular things in the investigation like pregnancy test if it is the reproductive age group, and other things are similar to in both males and females. These are the different diagnoses we make in the ICD-11, from the single use to recurrent use and final alcohol use disorders and induced conditions if it is substance induced psychiatric diagnosis. Then ICD, the DSM-5 also, these are the criteria we can use. Now coming to the planning of the treatment, the planning of the treatment has to be comprehensive and multi-pronged care, continuous and prolonged integrated biopsychosocial approach to care, and active collaboration with the family members because of the high comorbidity with the other setups, and if he has gynae issues and other thing, pregnancy with the obs-gynae people also needed. This is similar to the male, there is no particular things. And most important is the management has to be sensitive to the need of the female users and also needs to be evidence based. This is the broad goals of any treatment. The treatment basically vary according to the time frame. Either in the short, it is basically the management of withdrawal symptoms or the stresses. On the long term, the abstinent or the consequences, decrease the consequence of the substance use effect. And ideally, it will be maintain abstinence. If not, decrease the frequency and severity of the relapses and maximize the function in between. So the short term is the medical stabilization and engage the patient in process of recovery. Long term will be promoting abstinence and preventing relapses in patients with substance use disorders. The treatment principles in prior to 1970s, there was generic model of treatment in both male and female substance users. There was no difference. And in the early 1970s, the women's movement emphasized the role of gender in the initiation of substance use and progress to dependence and other effects. So basically the advisory by the SAMHSA people basically talks about that we have to acknowledge the importance and role of socioeconomic issues and differences among women and men, address women's unique health concerns, endorse a developmental perspective because the substance use might have an effect on children of the female and other aspects, and the long-term consequences of the children those who are using substance in the pregnancy, and attend to the relevance and influence of various caregivers roles that women often assume throughout the course of their lives, integrated multidisciplinary team, and also the trauma focus integrated treatment also being advised. Now coming to the evidence base for the pharmacological, this for the alcohol, basically they are talking about the treatment of alcohol use disorders in the withdrawal phase and also during the dependence phase. What we can see in this that like for withdrawal phase, the benzodiazepine, there are around 12 RCTs. We can see the female users are like benzodiazepine users are very, very low. And for treatment of withdrawal symptoms, male you can see it here, and anticonvulsants, the 17 RCTs and gamma, this is around 1 and 23 patients. So what they are this is for the RCTs. What they are basically talking about that in alcohol withdrawal symptoms, the benzodiazepine contribute 3% among compared to the male. Anticonvulsant, if there is 100 patients of using, there are only 3%, and it is very too low to establish the possible sex difference in response to the medication during the withdrawal period. And coming to the for anti-craving agent acamprosate and naltrexone, this study basically talked that they showed both medications are generally efficacious for women in decreasing the number of drinks and also the consequences of using the like health consequences and other things also decrease over the period of 6 to 12 weeks during the study period. There is another study which has naltrexone, which has they have concluded that the effect of naltrexone on women is currently understudied. There is not much evidence of the use of naltrexone in alcohol use disorders. Now coming to the opioid use studies, the studies have consistently indicated that treatment for opioid disorder is effective in both men and women without evidence of a sex difference in opioid use outcomes. So buprenorphine, methadone, all the drugs have been used in women opioid users. Now coming to the non-pharmacological, there are gender difference in the factors and social context associated with the relapse. In for male, it will be including living alone, positive effect of the substance and social pressures. In female, relapses have been associated with not living with one's children, being depressed, stressful marriages, and being pressured to use by their sexual partners. So while doing relapse prevention counseling in female, these aspects has to be covered. Coming to the motivation intervention, few studies have actually examined the gender difference in the effectiveness of motivation approaches. One study this published in 2004, there's a long back. Basically, it assessed the impact of individual MI session on treatment engagement and retention at 8 weeks. There was no difference between those who have given MI session or those who are given educational controlled. So it is a negative study in that way. Now coming to the trauma specific intervention, there are several interventions I have developed to integrate treatment for effects of trauma exposure within the context of substance abuse treatment. This is this was published in 2019. It was systemic review of 20 control studies involving around 63 records, showed treatment that teaches extensive coping skill to promote external safety, symptom stabilization and emotional regulation, combined with access to safe social support and external advocacy, may be particularly useful for women with more severe PTSD or for those experience ongoing victimization for whom past focused treatments are contraindicated. Now coming to briefly about the general principles in managing those female substance users in pregnancy and lactation. Try to avoid all drugs in the first trimester unless benefits outweigh the risk. Use an established drug at lowest effective dose. Avoid drugs contraindicated in pregnancy. Prescribe as few drugs as possible. Adjust the dose as pregnancy progresses. Usually dose increased is required in the third trimester. Ensure adequate fetal screening and refer to specialist services whenever there is a issue. Monitor the neonate for withdrawal effects at birth. Safety of the individual drugs in breastfeeding should be taken into, and all the medications, buprenorphine, naltrexone, acamprosate are the class C group. Now concluding, there have been tremendous gains in the recent years in our understanding of the influence of gender on the substance use disorders, their treatment and factors related to the outcome. There are few evidence-based studies which have shown that they are effective in few conditions, and there is a need for further studies on this aspect. In India, there are literature to tell the extent of problems of substance use in women. However, the data on evidence-based management of substance use disorders tailoring to the needs of our population are lacking. Thank you.